I just wanted to share a little bit that usually in the past we've sent things out, but we're trying to be a little bit more efficient and add things to the chat, to the document. So we're going to work on putting the PowerPoint in the chat today at the beginning and then at the end of the meeting as well. And then as today's being recorded, we can be able to send this to our YouTube transition team so that could get posted. And hopefully that takes about 7 days. And I think Don already covered the AI piece, so I think we're ready to jump in. Just an overview of today's agenda. Definitely thanks everyone for being here today. We have definitely a lot of folks from a lot of different agencies, so that's always great to see. We really want to talk about the big picture, social determinants of health and FCS, as well as I don't know if we have our teammates from WellPoint here as well to kind of also get that perspective of that piece of being an FCS vendor and working with our third-party administrator. Definitely going to talk about, supportive employment and supportive housing today, as well as some of the other programs that we have within our growing FCS family. And if there's anybody new who's thinking about being a provider, we have some information for that. We definitely like to have an interactive session today, so feel free to raise your hand or unmute so that we can address your questions as they come up. You'll definitely have the PowerPoint today, but I think it's most important to address questions that they as they come up.
Mhm.
And again, thank you for being here today. And as I said, social determinant of health is a central pillar to all the services that we do for, employment, education, housing, primary care, uh, early childhood development, daycare, all those different things, as well as that diverse piece of all the different agencies we have here. Definitely a lot of diversity in the audience, and HCA is really looking at creating that robust diversity of all the agencies because we know there's specialized populations out there that receive different services and need different types of supports. So we're really looking at continue to add diversity for that. But my belief is we really can't have the movement forward that we'd like in having stable housing and having people enter into employment or enter into education to improve their lives without these robust supports that were out there. So it takes a lot of, my belief, to run a successful program, it takes a lot of collaboration within state organizations or within your community coming together. I know Dawn and Anessa have done a great job of doing some collaboration out there in Spokane, and we've seen some duplication, across the state in King County and I think in Snohomish County as well. So we're seeing some of these things organically come together to really build a more supportive community for folks. Just a little bit about the history of Medicaid transformation. And I always rely on Dawn to talk a little bit more because she's been involved in some of that grassroots efforts out there and some of the pilot projects. But the services we have today are very unique and they come out of the Medicaid transformation project through the waiver that Washington worked really hard to have something separate to use the Medicaid dollars for employment and for housing, and to create the funding streams for the service contracts for that. So it's very unique as part of the waiver services that we do that's allowed us to implement all these different programs. But we had to get approval from Medicaid. So in our second MTP phase two that leadership put together because we had success with our phase one for the first 5 years. And now we have our second 5 year mission through 2028 to provide the services. We see a lot of services in combination with behavioral health, but because of the diversity that the HCA has really strived for, we've seen clubhouses, recovery cafes, smaller organizations that are recovery based to provide a lot of different services and collaborate with some of the other agencies to really have that full spectrum of care for folks. Anything to add, Don or Anessa?
Yeah, and I think one of the other slides talks about this a little bit, but there were pilot projects prior to the 1115 transformation project actually starting. Um, The state of Washington ended up with two policy academies, one that related to supportive housing, one that related to supported employment. In each case, we ended up doing strategic planning about, where we were at the moment, which was underserving folks related to finding employment and housing, up through the plans in regards to how to improve that. Um, Part of the process in those policy academies was to receive training from other agencies. More than one of the trainings in the Olmsted Policy Academy, which was the supported employment one, states came and talked about the 1115 waiver that they were using. And there was also a 1915I, and I can't remember what other Medicaid waivers were brought up as potentials that we could use. And the 1115 waiver was the one that seemed the best for the state of Washington. Had to go through a process with the legislature and, just kind of a lot of work in order to have the state plan opened and have it added to the state plan as something that was going to be part of what the state of Washington uses. Um, After the policy academies came the pilot project, Porch, Best, and others, where we used permanent supportive housing and individual placement and support and started collecting data to show to the legislature the worth of doing the services. And then fast forward to January of 2018, I believe, is when services started being provided. And so there was quite some history before FCS started in regards to that strategic planning moving forward, doing a pilot project, doing more than one, a number of pilot projects, and then being granted the opportunity to do FCS services.
You mind taking this one, Dawn or Anissa?
I'm
Yeah,
going to
happy
say
to.
yes because I can't read it.
Makes it easier.
Uh,
This slide illustrates some of the cool changes and additions to programs that came about with the second iteration of the Medicaid Transformation Project waiver. It was renewed in 2023, June of 2023. Fingers crossed, the waiver will be renewed again in 2028. But when that waiver was renewed, there came expansions with a lot of programs, such as for the older and aging population, like the MAC and TSOA programs, HRSN infrastructure, which is really exciting because that is a program which we can pay folks rent through if they are enrolled in Medicaid receiving FCS services. I think I'll talk a little bit about that later in this presentation. More access to services from folks who are being exited from a carceral setting. It used to be that we had to wait until folks were already out to start serving them, but now providers are able to meet with folks in jail or prison and provide services when they are, I believe, 30 days from being released.
and by the way, that's supportive housing only, not supported employment.
Right. Yeah, thank you for specifying that. And obviously we see housing and employment under foundational community supports. That's primarily what we're talking about today, but these are all some other programs that the Healthcare Authority has. And if you have questions about these other programs, maybe your agencies operate some of these too, we're happy to connect you to the right folks for that as well. And we're going to get into talking about the evidence-based practices for both supportive housing and supported employment. An evidence-based practice is based on rigorous research, and we can see across the board, if you follow this practice, you are going to get these outcomes. It's proven to work, and it's been shown to work across many different kinds of settings, many different kinds of providers. So when we hear us speak to fidelity to the evidence-based practice, that means how closely is your agency aligning with those practices in your policies and procedures, in the kind of services that you provide, and the way that you're offering services, in the way that you're interacting with clients. We do something called fidelity reviews for both employment and housing, and that's basically us from the state and also some peer agencies coming in to review your files, interview staff, interview participants, and see, are you following this evidence-based practice? And obviously, you want to know that so that you can get the good outcomes that are going to help keep people housed, help keep people employed. And obviously, when we have good outcomes, that means increased support from the government, increased funding opportunities, all of that good stuff.
Vanessa, there is a question in the chat from
Oh,
Sabrina. For providing services for inmates, do they need to be 30 days prior to release before the assessment or before receiving services?
that is a great question, and I would want to direct that towards, I'm not sure which department that would be. We will parking lot that one, and I will find the person to answer that question for you.
Great question. I just wanted to ask folks if people have heard of evidence-based practices before, or some of these things about fidelity that we're going to dive into a little bit more. Just, you can kind of, just put something in the chat, but I'm always curious to kind of see if this is brand new information or if people might be a little bit more familiar with it. I think this is something that comes up. It's just like, why is this important? I always see it as the kind of that foundation for quality assurance. If we're talking about a program, are we talking about services? Are we being intentional and following through with the services? And that's what I really like about Fidelity. It kind of shows us where we're at and how we're aligning with the services, how intentional we are. I used to use this as a tool for my leadership. If this is something we're embracing, these are the different things that we need to do, and here's the progression, so we can match the different anchors, because every fidelity item in employment has 4 or 5 anchors with it. So there's multiple elements that kind of really build your program around, so that we're having those intentional services. Plus, one thing I found out about fidelity reviews, it really brings people in the community together. One of the joys I have at Fidelity is bringing people from different agencies together as a team, so that we can go in and learn about different organizations, some of the things that they're doing really well, some of the things that need corrections, and how we put that input together. So it's always exciting to pull different folks to create a team for some of that. And hopefully this is also a tool for the organization, that you can say that you're meeting, fair, good, excellent. I can't remember the highest one for employment fidelity, even though I just put that in the chat in an earlier meeting. But really, kind of how we work together and how we're showing progression, and how we're meeting the elements. It doesn't always mean, how many people are getting employed and the types of jobs. All those things are important, but it really looks at, if you follow this recipe, if you follow these different steps, we're going to have higher outcomes for folks. And what that really means for me is that we're really changing people's lives for the better, in terms of getting into employment or education, stable employment, and also on the housing side, that we're creating those safe housing opportunities for folks to move forward.
I will say too, one of the bottom line reasons why Fidelity, as we were going through the process of the policy academies and the pilot projects and getting approval from the legislature and CMS and all of that kind of thing, one of the things that the legislature said is, if you're going to do this, you need to use evidence-based or promising practices. So this is a mandate from the legislature. This isn't us being, kind of arbitrary or whatever. This is, the legislature wanted the biggest bang for their buck. And so they said, if you're doing FCS, you're going to use evidence-based or promising practices.
It's been quite the journey, because wasn't that like in 2011 that the legislature did that, and all the work that's come up to where we're at today.
Oh my
So
gosh.
it's
Yeah.
really taken a lot of movement and support from the legislature and our community to get to where we're at today.
Yeah. Absolute truth.
So I think this is going to be Anessa's roadshow here for Principles of PSH.
Okay, so we're going to be talking about the principles of permanent supportive housing. And there's some confusion with the term permanent supportive housing, because we know it can also refer
Did I
to,
freeze or did Anessa freeze?
did I freeze?
I haven't seen anybody freeze.
Okay, everybody can hear me okay? Cool. PSH can refer to like a building with folks who are receiving housing services in it, or it can refer to this evidence-based practice. That's what I'm talking about today. It's an evidence-based model that connects folks who are unhoused to safe and affordable housing and provides those supportive services to help them keep that housing as well. Next slide, please. So when we say permanent, that means they can continue to live in that unit as long as they meet the obligations of their lease. It's not at all time limited. As long as they want to live there, they can live there so long as they're, paying rent, not breaking a lease, all of that stuff. Supportive means that they have access to the services and supports that they need and want to stay in housing. For example, that could include case management services. That could include being connected to SUD treatment or clinical services or peer services or employment. There's lots of different ways you can support somebody who is looking for housing or who is already housed. You can tie just about anything back to helping somebody maintain their housing. And then housing obviously refers to somebody being able to live in a private and secure place, just like any of us would expect to be able to do. The end goal with FCS and with PSH is always like their own private home that they can stay in as long as they want. And that's not to say that we can't utilize options like transitional housing or Oxford housing or shelters or things like that in the interim. Oftentimes, those can be a really great stepping stone to a permanent housing option. And sometimes not. Every person is different. We'll talk about individualized services a little bit more too. Next slide, please. So effective permanent supportive housing, we have a really good analogy for this. Basically, the participant is the driver of the car and you're the GPS. You are showing them all of the different routes that they can take, and you're giving them the pros and cons of all of those different routes. This one takes a little longer, there's some traffic over here, that kind of thing. But ultimately, they are in the driver's seat and they are making the decisions. Your job is just to provide unbiased information so that they have all the information that they need to make choices, right? We don't want to gatekeep or hold back any information because we feel really strongly about them making one particular choice or another. And they might not have all of the information about all of the different options. There's so many different kinds of housing and so many different ways to pursue becoming housed. We want to make sure that somebody is aware of every single possible option for them. And I would highly recommend motivational interviewing if that is a training that your agency can offer or can access. We are also, that's our job, is to help connect people to trainings. Motivational interviewing can be very helpful in helping keep somebody on track to meet those goals. Offering choices, pros and cons, again, just making sure the participant is informed. And obviously, everybody's housing needs are going to be very different. You might have a caseload of 25 people who are all looking for housing, and it's going to look different for every single one of them because they're going to have different preferences, different barriers, different housing situations that they're looking for. That's why services need to be very individualized. And ultimately, that's what makes it reimbursable by Medicaid as well, is because it is an individualized, tailored service. Next slide, please. Okay, I'm going to try to get through these quickly because if I recall last month, it took a while to do all of these, and I can do like a 2-hour training on the principles of permanent supportive housing, but I'll try to keep it brief here. Choice of housing is kind of the first and overarching dimension of permanent supportive housing. It should always default back to client choice, right? And what does this look like in providing services? This means, again, like I was saying, we want to inform somebody of all of the different kinds of housing options, including like room rentals, home ownership, Oxford housing, clean and sober housing, PSH buildings, scattered site, all of that kind of thing should be options that you're presenting somebody with. Choice of housing also refers to if, for example, you are showing somebody some open units in an apartment building, do they get to choose from multiple units? If there's 3 open units, are they getting a chance to look at all of them? It also means if somebody says no to some kind of unit or housing situation, are you going to continue working with them? We want to see that providers are willing to work with somebody and able to help them find housing that is suitable for them rather than just being like, this is what I have open for you. If you don't want it, I'm done working with you. We know that when folks have that autonomy and that agency in choosing the kind of housing that they're getting, they're going to be a lot more invested in keeping it, right? If you're living somewhere you don't like, why would you be interested in following the lease and integrating into the community and all of those things? We want our folks to like where they're living. That's a really important piece of it. And I always get a lot of pushback on this one because I know that in the whole state of Washington, housing is limited, housing is expensive. I know that sometimes you just kind of have to work with the options that you have, right? Some of our smaller communities, it's like you have an option of continuing to remain homeless or take this bed in a transitional housing situation. And some folks are going to say, nope, I'm just going to sleep in my car. Let me know when something else is available or whatever it might look like. Again, that's their choice. That is the most important thing, is honoring participant choice and making sure that they have all of the information to make the right choice for themselves. The next one is separation of housing and services. And this is really important for any agency that owns and operates their own housing, whether that is permanent supportive housing or they master lease scattered site, or whatever that might look like. It's very important that the role of the landlord or property manager is entirely separate from the role of like the housing support person, right? Because both of those people, in a way, are in a position where they're trying to help you with your housing, right? But the conversations you have with them are going to be very different. For example, you can tell your housing support specialist or case manager or whatever, your particular title is, you can tell them, I'm having a really hard time setting boundaries with my friends, and I have 2 people that moved their stuff into my apartment and they're now living here full time. Your case manager is going to be able to tell you like, okay, let's have a conversation about setting boundaries. Let me see what resources I can offer your friends so that I can get them their own housing situation. There's going to be problem solving. And whereas if you tell your landlord, I let 2 people move in with me, that's going to be like, I have to evict you and I'm giving you a 10-day notice, right? It's very problematic when the person who is in charge of somebody's tenancy is also the person who's supposed to be providing support services. So practical separation can look like, first of all, they should be 2 different people in 2 different roles. We should be able to see very different and distinct job descriptions for each of them. Housing specialists should never be like collecting rent, posting notices, doing, like monthly unit inspections or anything like that. And a landlord should not be, doing case management, probably not giving people rides, things like that. They should be very distinct. And it can get a little bit blurry sometimes. The roles can get a little bit fuzzy. It's kind of a fine line at times. But that's always something I'm happy to talk through for training and technical assistance purposes. The next principle is decent, safe, and affordable housing. And this means we want folks to ideally be paying 30% or less of their monthly income towards rent and utilities. And if they are living in a subsidized unit, that's always going to be the case. But if somebody is not utilizing a subsidy, is just using their own income, they can, again, it defaults back to choice. Somebody can opt to pay more, like 50% of their monthly income. And it's important to have a conversation with them about, how are we going to budget and afford everything else as well. The safe and affordable, the decent and safe part refers to, is the unit passing HHS and HQS inspections? And again, if they're utilizing a subsidy, it has to pass an inspection. If they're not utilizing a subsidy, though, they can opt to live somewhere that for whatever reason doesn't pass inspection. And again, that just looks like having a conversation about, hey, this unit didn't pass because the fridge doesn't work or whatever. How are we going to keep your food stored safely? The safe part also refers to like, do they feel comfortable in the building? Do they feel comfortable in the neighborhood? I've totally had people pass on certain housing situations because they're like, ooh, you know what? I used to be involved in gang activity in this neighborhood. I don't want to be housed anywhere near here. Cool. We will put you somewhere else, even though you really liked the apartment itself, but you don't feel comfortable in the neighborhood. Advice I give to folks helping people find housing too is like drive by there at night with the person. Do they like it as much at night as they do in the day? It might be a very different situation. Integration is the next one. And this principle says that ideally folks are living in scattered site housing that basically is integrated into the community and looks like any unit that any of us might rent, right? It's not a big PSH building with like an agency logo on it. It is very inconspicuous. Somebody can just walk in there, mind their own business, just a regular housing situation. That's the ideal for housing. And again, like I was saying earlier, some people will opt to live in a PSH building or opt to live in transitional housing. There's totally nothing wrong with that. It's the person's choice. Just we see the best outcomes come from when somebody is able to integrate into the community. Because as we know, unfortunately, a lot of those other housing options come with a lot of stigma attached to them. And if we want our folks to be able to recover and heal, find employment, make friends in the community, all of that kind of thing, it's just easier to do if you're living somewhere that looks like a regular unit. Access to housing is the next one, meaning it's very low barrier. We are going to help somebody regardless of what kind of hurdles they're coming in with. For example, we are not expecting people to be clean and sober before we serve them. We are not expecting people to we're still going to work with somebody if they have criminal background, if they have evictions, if they have no income. All of those are things that you've probably encountered before, and we're going to take somebody and all of their challenges and barriers and work with them anyway, without providing, undue hoops to jump through. Rights of tenancy is the next one. This is basically just we see the best outcomes when people have regular standard leases with no extra provisions in them, and they have legal rights to the unit, right? We want to see that folks who are housed have a signed lease with their name on it. And we don't want to see any additional lease provisions such as, no guests after 8 p.m. or mandated drug testing or mandated participation in services. Again, depending on the kind of housing situation somebody opts for, those things might be present, but ideally they're in a regular unit in the community, have a regular standard lease. And then the last one is flexible and voluntary services. And there's a lot of different components under this one. One of them is we want to be able to meet people where they're at. That means physically as well. We're not expecting folks to come and meet with us in an office. We are willing to meet with them at the park, at the grocery store, at the encampment, at their own unit. We want to make our services as accessible as possible, and we're going to let them choose when and where they meet with us, how often they meet with us, what we're talking about while we're there, obviously. If somebody is having a crisis and needs to talk to you several times a day for a while, that's totally fine. Or also, if somebody's like, hey, I'm fine for now, just check on me in like 3 months. That's totally cool too. Again, it all comes back to the participant's choice. What are they saying for themselves is going to be the best for them. Flexible and voluntary services also means being able to connect folks with other supportive services in addition to housing, like I was talking about earlier, employment or peer services or treatment services, any of that kind of thing. If they express an interest in, we want to be able to either provide under our own agency or do a warm handoff and make some kind of connection to help them in getting that service. Flexible and voluntary services also refers to the availability of services. Are we strictly offering case management and support through like 9 to 5, Monday through Friday? Or is there like an after hours number they can call? Or are some staff having like staggered schedules so that maybe there's somebody available on a weekend? Or, if somebody becomes employed and now they need to meet with you at 7 p.m. instead of 4 p.m., can you accommodate that? Are staff able to flex schedules for that? And flexible and voluntary services also refers to having limited caseload sizes. So we advise for 15 or fewer active participants for supportive housing. I know that that's a hard one to make pencil sometimes. And we know that folks are able to receive, higher quality, more dedicated services when you don't have 40 people on your caseload. Any questions about any of the principles? All right, then I'll pass it. Oh, that's right. We rearranged the slides in kind of a weird way. Let's talk specifically about FCS. Oh, I've got a question in the chat. How often should you meet with somebody? Um, The FCS recommendations are you should be seeing somebody face to face at least once a month. We know that doesn't always happen. And like I was saying too, if somebody says, you know what, I'm fine right now, just check on me in a month or so, that's totally fine too. I wouldn't consider that to be an active participant though. That would be somebody you're more like trying to reach out to. But sorry, short answer is you should meet with somebody as often as you need to meet with them and as often as they want to meet with you, so long as it's helpful. And that's going to look very different depending on who you're working with and what is happening at the time, because there's totally some participants that would totally meet with you every single day if they could, just to like chit chat because they like you. You don't need to do that. And also, there's some people that probably try to avoid you, and you need to meet with them more often in order to help them with their goals. It really just depends on the participant. There's no
Yeah.
hard and fast rule about you must meet with them, once a week or twice a week or anything like that. It's very
Yeah.
individualized.
Keep in mind, you might have to front load some things. In supported
Sure.
employment, when a person's looking for a job, sometimes there's an immediate need. And so potentially you'd meet with a person, I used to meet with people sometimes twice a week initially to help them apply for the jobs to get on it right away so that they could get the job quickly and then fade out a little bit over a period of time. Keep in mind that WellPoint has, and we'll talk about it a little more later, they have the authorization period, but they also have the exception to the rule. So if for some reason a person needs more services in an authorization period than what the period allows, you can ask for more. That's the exception to the rule. And you can
Yes.
get the number of hours needed for the person to succeed based on their needs.
Really feel like we should have put this section first. I don't know why we arranged it this way, but FCS
That's
is
not
a
goofy.
targeted Medicaid that helps eligible clients with their complex health needs, and the goal is to find and maintain housing and employment. It's not an entitlement or a wage enhancement or any kind of ongoing rental payment, but we do have some really exciting new programs that are helping folks pay their rent, which is really cool. And I'm going to talk about them a little bit later. But that's not FCS. FCS is reimbursement to agencies for providing these targeted individualized services under Medicaid.
I think one of the unique things is this a fee for service?
Yes.
When I started out in social services and working with this, we used to have that for a lot of services, and then that went to managed care. But because of the Medicaid transformation waiver, we're able to bring this back for services. So it's very unique in terms of services that you can provide out in the office or collateral out in the community for folks. Now, that is kind of weird. I'll have to change that next go around.
So back to supportive housing, these are services that you can bill for, and they're split into pre-tenancy, so before somebody is housed, and then tenancy sustaining is the next one. But some things you can help with somebody, and this is hardly a comprehensive list. There's just about everything you can make tie back to housing, but any kind of conducting assessments, including like a housing assessment of sorts, like what does your ideal housing situation look like? If you've been housed before, what went well or what didn't go well? What are your deal breakers in housing? We want to see questions like that because I'm sure all of you have encountered before folks that are like, I don't care where you house me, I just want to be inside somewhere. A lot of people are, in that survival mode at that point. But once you talk to them more, you might learn, oh, they actually do have some important preferences and considerations. And having a really good assessment can help somebody be a little bit more clear about what would help them be successful in housing. Any kind of care coordination, and I want to note this is a collateral service. So care coordination, you can bill for with or without the person present with you, as long as it's external care coordination, by which I mean you can't like staff a situation with your boss and count that as care coordination. But if, for example, you talk to a landlord on somebody's behalf, that could be care coordination that you could bill for without the participant next to you. Or, talking to somebody's primary care provider or something like that. Any external party that you are working with to assist this person in their treatment and their goals, that's going to count. Obviously, ideally, the person is always an active participant in the services that you're providing, but we know, if it's 8 a.m. on a Monday, you get a call from a landlord first thing, the participant's probably right next to you. So as long as in your case note you can reflect, why you were meeting without the person and how you're going to relay the information to them, it's totally fine to bill for that anyway. Development of community supports, so helping folks figure out how to access other services. Even, this could look like helping somebody navigate the bus route where they're living, or helping them access food banks, or things like that. Treatment planning, establishing long-term and short-term goals. This is a really important one as well. We'll talk a little bit more. Oh, I don't know if we do talk about treatment plans in this training. We also have a documentation training where we do more of a deep dive into things like treatment plans and case notes. We want to see that when you are working with clients, every meeting you have with them ties back to some kind of goal that they're working on, whether that be related to housing or employment or income or relationships or any of that kind of thing. And we want to see that people's goals are constantly evolving, right? Anytime you make progress or meet a goal, there should be a new goal to replace it. That's why we can continue working with people, is because we're continuing to support them with things. Any kind of advocacy and landlord liaising, especially, for example, we're working with a person who, on paper, when a landlord pulls a background check, they might not look great on paper, right? They've got evictions, they are low income. Helping somebody advocate for themselves, either on paper or coaching them through having a conversation with a landlord face to face, that's really helpful in helping somebody become housed and helping them build the skills to become housed if, they need to do it again on their own later. And then any kind of financial skill building or benefits support, that can look like helping somebody budget, helping somebody get on benefits if they're not already, helping somebody pursue employment as well. Next slide, please. Tenancy sustaining services. A lot of these are very similar, but I just want to highlight a couple of things on here. Like I said, employment or vocational support is a big one. I have worked with so many people that once they got housed and kind of got out of survival mode and started to feel safe and secure in their housing, something that was really common was folks being like, I don't know what to do with my time. I'm bored. I just kind of hang out here all day. It could really lead to a pretty big decline in mental health as well. So it can be a great time once somebody's stably housed to say like, hey, what do you want to be doing with your time? Do you want to have more income? What do you feel like you're good at? What do you enjoy doing? All of those questions can be a great way to open the door into, would you like to go back to school or become employed or, get a certificate, those kind of things. Development of independent living skills as well. Oh, Devin, go ahead. I see you have a hand up.
Oh, thanks. So should we have a treatment plan for our clients in our EHR, or are you guys expecting that?
Yes. Yeah, there should always be a treatment plan anytime you're billing for somebody, because we need to see that all of the interactions you're having them tie back to a specific goal in the treatment plan.
Okay, that's great. And then who can do the treatment plan? Does that have to be somebody specific, or?
It can be whoever the person is working with. It should be, whoever their primary contact at the agency, their case manager, whoever that might be.
Okay,
Whoever's going to be working with them.
Okay, great. And then to get clarity on the case management designation, I know that's changed and now they're requiring case managers to be SEDTs. Are you guys like falling under that kind of?
No, we don't have any kind of requirements like that for folks billing FCS services. A lot of agencies, a lot of time it comes down to the agency and what their preference is for staff requirements. But I've seen things all the way from like if you have lived experience, you can get hired, to like you have to have a bachelor's. It's more agency preference than anything.
Okay, great. Thank you.
Okay, development of independent living skills. So something that I've also seen a lot from folks that have maybe especially been unhoused for quite a while, like, 15, 20 years, might lack some of the skills for living indoors that we take for granted, right? This can mean this is why it's so important to meet with people in their homes if that's something that they're comfortable with and something that you're comfortable with. It can really give you a lot of insight into what they still might be needing support with. Like, for example, I worked with a gentleman that even after he got housed, he continued to only eat chips and drink pop because and I asked him why, because when he was unhoused he was saying how excited he was to be able to like make sandwiches and things like that. And I was like, hey, I notice you're still eating the same stuff. What's going on with that? You have this kitchen and this fridge now. And he told me, well, I don't like buying produce because I cut it up and then it goes bad. And I was like, oh, you don't have any Tupperware and you don't know how to store food after you cut it up and open it, right? Like, that's a problem I can help you solve. Similar things are, somebody might not know why you can't do your laundry in the bathtub or why you can't shower without a shower curtain. Having conversations like that can help prevent flooding and damages that are going to get somebody evicted. So it's going to be really important to have those little conversations that are going to proactively prevent a lot of difficult situations later on. Increasing ADLs as well. We know a lot of our folks probably qualify for caregiving services and aren't able to access them when they don't have an address. So hooking somebody up with a caregiver can also be really helpful in helping them maintain their housing. If they need help with things like cleaning, cooking, having access to those services is going to help them maintain their housing. Okay, I'm seeing lots of questions popping in the chat here. Is there anything I didn't answer that we're still waiting on?
I don't think so, Anessa. I think they've been answered in the chat. So I think we're up to speed at the moment, but correct me if I'm wrong, folks.
All right, we can go ahead and move along.
Sorry, I just have one more question
Yeah.
on the treatment plan. Are you guys expecting that to be done prior to their application being sent to you or after, or does it matter?
Sorry, could you repeat the question?
Yeah, so for the treatment plan, are you expecting that to be done before their application, like during the application process where we're sending you the referral, or does that happen after they've been accepted?
It can be done really around the same time. The treatment plan doesn't have to be done like in one meeting or done immediately. It should just, I would expect within the first couple times that you're meeting with somebody, you have a completed treatment plan. It's really just part of the like rapport building process and figuring out what kind of housing goals they have. We want it to look like that rather than just like, this is another form that we're filling out and boxes we're checking. It should be very conversational and
Right.
really help build that trust.
Per the golden thread, you can't really do the treatment plan until you've done the assessment. And because you'll find out in the assessment what the person's needs are, from that, then you'll build the treatment plan.
Okay, great. Thank you.
One of the things we used to do is just have a very general short-term goal. I want to return to work. And then after getting to know the person and do the profile, just like within housing, then we could go back and fine tune the treatment plan goals to really reflect what the person's looking for.
And on that note too, I would really like to preface, it's really helpful to proactively, like when you first start meeting with somebody, do let them know there's lots of things that you can help them with beyond just, I'm going to help you find housing. If we set the precedent that that's your only role, is just helping them find housing, a lot of people, once they get housed, are just like, cool, I don't need you anymore, bye. And we know a lot of folks are going to need that follow-up support to help maintain that housing. And we want to, offer people all of the services and supports we can. And that could include so many things, especially after they're housed. There's lots of other goals that you can work on somebody with that again, you can tie it back to housing, but they might be related more to like quality of life kind of things, relationships, physical health, all of that kind of stuff.
I see, Darren, you put in our FCS 101 series. We can also at some point in time put in, somebody had asked about, a couple of people have asked about golden thread. Anessa and Darren and I, or at least I think Anessa, Darren and I are going to be doing a documentation training every other month. And then those between months, we're going to be doing golden thread training. Rutgers University developed a toolkit for us and a train the trainer kind of training where we are going to be doing the webinars for Golden Thread in this upcoming year. They had been done previously by Rutgers. They do show up in the YouTube channel. I have a list of them I can kind of send out the separate links to later if that's a need. So next slide, Darren. Our favorite stuff.
It is our favorite stuff.
Uh,
You want to take the first half and I can do the follow-up?
sure. Well, and we kind of got started here pretty quickly. I'm going to give just a really brief. I see, Kristen, you said, what is Golden Thread? When you're talking about Medicaid documentation, they have expectations. And somewhere, someone along the way ended up calling them a golden thread because they're kind of linked one to another. That assessment, the treatment or service or rehab plan, employment plan, housing plan, whatever you call it, and then the progress notes are kind of that golden thread. More to follow on that if you attend our golden thread trainings that I was just mentioning. So related to principles of individual placement and supported employment, which is the evidence-based practice for supported employment. If you look on the SAMHSA website, they have a toolkit for IPS. And then IPS also has their own website. So if you were to put in ipsworks.org, the entity, the IPS Employment Center, that originally was with Dartmouth University is the one that developed these principles. I think they're based on common sense. I think they're based on, obviously trials and what's worked, much like Anessa was talking about earlier related to fidelity and the fact that evidence-based means that they've done research studies and that kind of thing. They've done a boatload of research studies. These are proven to work. My colleague Kimberly always calls it a recipe for a cake. And the closer you follow the recipe to for the cake, the better your outcome is going to end up being. So the number one thing is competitive employment is the goal. Having done supported employment for 35 years, things have improved a lot, as you might guess, over time. I see Darren laughing. He's been through the same experience because he's provided for about the same length of time. They used to have sheltered workshops, meaning that folks with disabilities would be grouped together. Sometimes they would do what was called sim work or simulated work. Sometimes we'd have fakey tasks that they would do to teach them how to work. Sometimes, like one of the agencies that I worked for had a contract with a tractor manufacturing company, and we did the kits for the wire harnesses and all the ends that went on those wires for the electrical stuff that went into the tractor. And so people would have to choose, a couple of these, a couple of those, so much of this, and put it in a bag. And we did, as an agency, get paid for it. And then we turned around and paid the individuals sub-minimum wage, which it was heinous and awful. It's Department of Labor sanctioned ability to pay people with disabilities less than the minimum wage. So fast forward to IPS. The jobs gotten for individuals are in locations where others without disabilities are working, paying at least minimum wage, no minimum wage on this one. Open to anybody to apply for. The one exception, and it's not an IPS principle, but the one exception that WellPoint allows is called job carving. Wow, I'm having problems with my words. I didn't drink my coffee soon enough today. We'll get to that later when we talk about billable services. So for IPS principles, competitive employment is the goal. It is actually jobs in the same location as other people. Good question, Kim. It's individual placement and support is the name of the evidence-based practice. IPS supported employment is integrated with treatment. When it was first developed, it was actually developed for people with serious mental illness, and it was developed to be used in behavioral health agencies. So when you see things like it saying integrated with treatment, it really was integrated with treatment. It was integrated with therapy and management and, whatever else that went on in a behavioral health agency. Fast forward to the state of Washington. I love the state of Washington. I love what we've done, and we're considered leaders. We use IPS with a bunch of different folks and by a bunch of different agencies, Goodwills and community action programs and independent contractors and behavioral health agencies and a variety of others. So where it says IPS supported employment is integrated with treatment, substitute that for support services. So let's say somebody is in IPS and you're working with them as an individual. And that person is also receiving services from maybe Department of Corrections because they've been previously in a carceral setting. You would want to work with that DOC worker in order to make sure that whatever job you came up with fits whatever the DOC criteria are, that it fits whatever the release agreement is in relationship to the person leaving the carceral setting and going back into the community. TANF is another example. I worked with a gal in the bunch of years ago on my caseload, and she came in and I was talking to her and said, what is it you'd like to do? She said, well, I'd really love to go to college. And I said, okay, let's do that. And she said, I can't, I'll get sanctioned. I didn't know what she was talking about. Fast forward to the fact that she was on TANF for Work First. They have what's called an individual responsibility plan. Each person in TANF for Work First has an IRP, individual responsibility plan. It's a treatment plan. In that plan, it says whether they're going to do work search or college. Hers said work search. If we had done the college route, she potentially could have gotten sanctioned and lost her TANF money. Obviously, you'd want to collaborate with the TANF worker if a person's on TANF to make sure that what you're doing with them also fits what's in the IRP. So where it says IPS supported employment is integrated with treatment, the idea here, in kind of the larger world that we're living in now, is that it's integrated with whatever other paid service providers are working with the person so that you do no harm, because you actually could do some harm if you didn't know what was going on in those other circumstances. There are expectations related to, kind of levels of contact and that kind of thing. One of the ideas within this, integrated with treatment is that where your referrals are coming from, and the largest groups of those referrals, let's say they are from DOC, that periodically you should have meetings with DOC just to staff folks, make sure that you're still on the same page and providing well-coordinated services. One of the other things that's in one of the couple of principles that relate back to the integrated with treatment is that it says that you should be housed in close proximity to the folks that are providing referrals to you. One of the things that we did, I worked for a behavioral health agency in Moses Lake. We became a WorkSource partner because we worked at that point in time fairly closely with DVR, and that's where DVR is housed. And so we actually had a desk at WorkSource. It was amazing for a variety of reasons. We got to do education with WorkSource staff who had some pretty skewed ideas about people with mental illness and behavioral health issues. And so we were able to do education and kind of change minds that way. But we were also readily available if somebody walked in the door and they needed a greater level of support than what perhaps the employment security staff was able to provide to them. So sometimes that in close proximity to could even be, a setting outside your own agency, at least some of the time. Zero exclusion, and I'm going to back up for a second. There's a lot more to that principle than, or the couple of principles under integration than that. I'm giving you a taste. We do, a much more comprehensive IPS training at various points in time. If you want more about that, let us know. We'll go into more. Zero exclusion is what it sounds like. If a person says they're ready to work, they're ready to work. Same as Inessa was talking about low barrier. It's the IPS version of low barrier. If a person has substance use disorder, if they have if they're symptomatic based on their substance use disorder, if they have past justice involvement, if they've got, whatever it might be, None of that precludes them going to work. And I want you all to consider, and I don't want you to answer me. I'm going to ask a rhetorical kind of a question. Don't answer. Are all of you ready to work? I'm not. Not always. I have anxiety disorder, and there have been times in the past where I've had panic attacks when I've done presentations. Some folks would say, I'm not ready to do this job. They'd be wrong. I've seen the same thing happen over and over and over again with people on my caseload over the years related to that zero exclusion. Darren, I'm going to tell my favorite story real quickly. Individual on my caseload who was actively using meth. First couple of sessions, she just sort of hovered over the chair for about 15 minutes and darted out of the door. And I chased her down the hall and got rescheduled. About the third session, I asked her what she wanted to do, and she said, I don't know, I just want it to be legal. She'd been a drug dealer and a prostitute and mugged so many times from behind that she had serious PTSD. She didn't know what she wanted to do, so we accessed an interest profiler on the Career One Stop website. It also exists on the WorkSource website. Took about 15 minutes. At the end of it, she said, I want to be a welder. That wouldn't have even been in my list anywhere of potential jobs for her. But we went out and talked to the college instructors, helped her do FAFSA, helped her get out of default in her school loans by referring her to DVR. They paid for the first quarter of college, which got her out of default. So she got started back into college again. Took 2 years to get a one-year certificate in welding. Ended up getting a job at a scrap yard using a cutting torch. I apologize if you hear the sirens in the background. I'm not sure what's going on. Sounds like a fire someplace. The side effects of that whole thing of getting the job and going through college and all that, she quit using meth. She joined NA. They became like her second family. Her real family started having returning to her life. Her mom and stepdad had essentially disowned her, and she had contact with them again. Her adult kids that had been taken away by CPS had contact with her again. You can see that the way she started out actively using meth, really not engaging until about the third session, I could potentially have said, you don't fit, and I didn't. And nobody's supposed to. That isn't a me thing. That's a nobody's supposed to do that. You're supposed to give the person the benefit of the doubt. If they say they're ready, they're ready. Boy, was she ever. Absolute, the very best success story I have in my kind of, list. And the one that I want to share just to prove people can overcome anything that they want to. That's not for us to say, that's for them to say. So that's what zero exclusion is about. Kim, yeah, I love that story. It still feeds me. It feeds my soul. Client preferences are honored. Have you ever been in a job that you hated? I have. We all have. And so we try our very best not to do that to people by helping them to look for jobs that fit their skills, interests, and abilities. When we do a fidelity review, we look at progress notes and see if the person said in the assessment or the career profile that they want to be a janitor, what are the jobs we're helping them to apply for? Are they janitorial jobs? Or if they want to be a Batman. This is another one of my stories. Gentleman said he wanted to be Batman, and what we did was to sit down with him and say, what about Batman do you like? We didn't say, you can't be Batman. It's not real. There's only one of them or whatever. We did, I think, tell him there was only one. So what other things might you want to do? What about Batman do you like? It was the cool car. Sometimes you have to do a little digging to find out what that preference might be, but it then should show up in the assessment, and we should be able to see that if they said they want to be Batman / work with cool cars, that when you're helping them look for jobs, you're looking for the cool car kinds of jobs. Sorry, sirens again. Holy smokes, something bad's going on. Darren, did you have things to add? And then over to you.
I don't. I just want to kind of check with the audience if they had any other thoughts or questions. Saw some things in the chat before we dive into the next set. Thanks for the great stories, and I didn't hear any sirens, so Um,
Oh, good.
that's good.
The microphone does a great job of filtering stuff out, I think, because man, it was loud.
I think it does. So the next thing we're gonna oh yeah, braiding services with DVR. That's great with that collaboration and integration. I think that's so important to access that community service for folks because they definitely have some specialized services and specialized supports that can do to really support somebody in that transition to employment or school. Was
Well,
your
I think Brian, our next slide actually goes over some of that. So more will be revealed, as Darren always says, in
stay
just a few
tuned.
minutes.
So I'm going to jump in and talk about benefit planning and education. And Dawn mentioned a little bit, we really don't want to do any harm. We really want to support people on the journey. And a lot of people I worked with in social services did have, federal benefits, state benefits, and to be very aware of what those are. Not everybody is forthcoming to share what their benefits are or to say that I might need some help. I've seen a lot of people say, no, I'm fine, I'm good. You don't have to tell me anything about my Social Security. I know it all. It's just like, okay. But it's one of those dialogues that's important to kind of have over and over, particularly if somebody's getting closer to, in that job search and maybe having some interviews really talk about how earned income will really impact their federal benefits, particularly Social Security. And right now, there's been so many changes going on in the background of Social Security. It's really important to be updated with some of those and just know some of the things when you're working with folks to try to get some information that there's been a lot of uh, staff released from Social Security, so it might be harder to get some of the information. But I really encourage agencies to have something more than just what's in the career profile to talk about benefits. There's some tools out there that I think are really important to be aware of, and different tools you can use to kind of go through the calculations to see how earned income would impact your supplemental Social Security check, SSI check, or Social Security disability check to see how it would impact those specific benefits well. And in Washington, we're grateful to have two providers that contract with Social Security. um, Dawn is really good about remembering their names. They're interchanged in my mind. But we'll have to kind of look and maybe add those to some information. But it's definitely something to look into. And the whole process is more than just asking person a couple questions about Social Security. It's really diving in to kind of see maybe how earned income will impact your check, how earned income might impact your SNAP, how earned income might impact your housing subsidies. So we're covering all those different bases as somebody is going in moving forward because that's that client's preference again. It's that individual choice. I'm going to support you moving ahead. Just be aware of some of these challenges that might come up, and we'll have to have kind of a plan B to support folks with some of that as well. The Division of Voc Rehab is another partner for that. During COVID, they opened up their process for people to access a certified benefits planner during the application process. So that's a big win in terms of trying to get that expertise and definitely a very thorough evaluation of where somebody is at in terms of that. So definitely some great resources to be able to access with that. And Social Security is really fluid. Social Security Administration is really fluid right now. If you run into a case where somebody might come in on your first meeting and they talk about overpayments, that's a real critical thing where they had worked, earned income, and one, maybe they didn't turn in the pay stubs to alert Social Security in a timely manner, or something else could have happened that would put somebody into an overpayment where they're going to ask for all their money back. And sometimes it takes Social Security a while. I had somebody that had over $30,000 of an overpayment that we had to work through to show that she did all the correct things about notifying Social Security and following through the process. And she was very organized. She kept records of everything. So whenever you deal with financial planning, benefit education, always keep some copies with those. So, or if you have any questions, please reach out to Don or myself. to talk more about it. I'm very passionate, and I know it's something that's very fluid right now for folks. Rapid job search, it's like getting back to that intentionality that we talked about, social determinants of health and FCS. If we're saying we're going to do employment services and focus on the number one on this list, competitive employment, what are we doing? Are we gathering information, trying to learn about the person's preference, and then just let it sit for a while and maybe talk about some other things and draw the process out for an extended period? Or are we going to be intentional and start developing that resume, looking at references, looking at specific transportation to help somebody get to work in a certain area? Talking about meal planning and lunches, talking about all those different things, talking about clothes if they have clothes to go to work, or kind of a system for hygiene and washing those clothes so that they can be ready to go for the job. All those kind of things. What intentionality are we going to be focusing on this bridge? And Fidelity says for high fidelity, that job search happens in the first 30 days. Doesn't mean they have to go out and get a job, but we're starting that intentional process. And the supportive employment staff are going out in the community, or maybe the person says, Darren, I really don't want to go out in the community right now, but I'll take that resume that you created with me and I'll start going out. That's part of that rapid job search process. For high fidelity, again, a really short time frame, but I've also seen some people that's not like till 270 days that there's been these meetings and discussions, but all they are, they're talking about things, but they're not really being intentional going out in the community, engaging with employers. And that's a lot of what this model is how we engage in the community to support the people working for it and make connections with employers or schools as well on the community. So Don would always tell me, Darren, it's not, rapid job get, it's that search process that we're starting that process and creating that collaboration with employers in the community. Um, Job development, it's not just something you can kind of pick up. There's a lot of different parts to the puzzle or to the machinery in terms of the systematic pieces. We encourage people to track data for housing and for employment, and we have some data trackers, job logs that are available on our Pathways to Employment or their Pathways to Housing websites. Some of these initial tools, because we want to see where people are at and what programs are doing, particularly from a fidelity reviewer's perspective, that they're meeting, they're tracking some data, they're meeting with the individuals, and that they're connecting with employers or schools out in the community, and that they're spending time in the community as well to kind of build up these relationships and meet people where they're at. I've always found that people are a little bit more comfortable. I used to work at a behavioral health facility, a large one, so people had some, there's a little bit of stigma. It's like, I really don't want to meet you at that facility, but I'll meet you at the library. I'll meet you at the park. I can meet in some of the different areas to do that. So be sensitive to some of that. As part of the systematic piece of job development is that we're also looking at those employer contacts and having a goal of 6 of those contacts a week, plus looking at the types of employers. So they have some diversity of employers and diversity of jobs, that we're not just getting everybody a job at Safeway and calling that good, that we're looking at that individual choice. Definitely, I've worked with Safeway. They've been a great employer for a lot of the people I've worked with, but not everybody comes up with that same idea of where they want to work. So we have that diversification of the jobs and the employers that we work with. One great thing about FCS, it provides us this ability to have time unlimited support. Granted that reauthorization is every 6 months, but it gives us that option to continue to provide services as long as a person is requesting that kind of help. I've worked with people who are able to go to work and do great getting a job, but then they don't last more than 60 or 90 days. Or I've had some people that work for years, and maybe they say, Darren, maybe I just need a phone call, once a month, or I need the flexibility that I can call you every 6 months to do a check-in to kind of see what that need is for folks. Definitely, I encourage people, to have that assertive engagement in the folks to kind of see what the services are needed. And as Don mentioned, we kind of pull back and let people, be successful on the job site. And then kind of decide how much engagement or interaction that they need to allow them to kind of close that chapter off, in their progression, and maybe they're going to, just focus on what they need to do, and maybe supportive employment isn't really needed. So it's always good to see people graduate, and sometimes people transition off Medicaid. That it's just like, well, Darren, I've looked at some of the costs, and it's going to be cheaper for me just to take insurance with my employer. So, I'm planning for that Medicaid piece, you know, to stop, but I'll have this backup plan for other health related needs through the health insurance there. So it's all those different conversations I have with folks to see what the amount of time that they need and the support that they need on the job to be successful. Yeah, thanks, Brian. That's an important thing. I still hear questions about benefits of like, well, I got Social Security, I can't work, or I have this and I can't work. It's a lot of fear. And I think this kind of thing has been around since I started, in support employment services 30 plus years. It's just beyond me that that myth is so primary out there. And I think it's up to us to say, I understand that you're scared because it might also relate to the family members. Families can get conditioned to expect this check every month. And now here comes Darren with some ideas like it's going to disrupt their comfort level. It's going to disrupt the system that they have built. But it does take some times for the conversation and to kind of show that it's actually going to be healthier for the person. It can be financially better for the person and potentially the family for them to go to work. But it's very individualized to kind of break through some of those, particularly with some of the young adults who might still be living at home, and have a significant other or a parent to kind of do some of the education around folks to see what might be some of the challenges and kind of educate to work around that there. So,
Well, and
yeah.
Kelly, I see your question about when clients choose to start application for disability and no longer want to look for employment, do employment services end at that time? I don't know. It's not as easy a question as that. I don't think. And the reason I say that, not because it's a really good question that you pose, but people will sometimes say they don't want to work because they're fearful, because they've been told they're a piece of crap all their life, because, maybe a therapist has told them somewhere along the way, you can't work, that's too stressful. When in fact, being unemployed is far more stressful than working a lot of the time. So I think it's at that point, you delve a little more. Tell me why you don't want to work. Talk to me about that. Let's discuss. Um, Sometimes it's not about asking about work at all. Sometimes when people end up being referred to employment, it's because a case manager has said, are you bored? Do you have enough to do with your time? Do you have enough friends? Do you have enough? I mean, what are the things that we get from work? We get a lot of those kinds of things. And sometimes it's having the conversations. I always kind of refer back to Maslow's hierarchy. Do you feel safe where you're living? Maybe if you get a job, you can afford to buy a house or pay for an apartment in a different neighborhood, and sometimes sadly not. Um, but it's at the very least the start of another conversation to kind of delve a little deeper and find out what's behind it. Because a lot of times I find that fear and lack of knowledge is behind it. And so, you don't necessarily just take it as face value, but it's a kind of a gentle dance in regards to how you address it and the questions you ask and how you move forward, and just recognizing it may not be face value. It may not be that they truly don't want to work. It may be that they don't understand, or 100 other reasons.
Or that they've been conditioned, even like you say, Brian. I've worked with people who start that process for Social Security and said, I can't work because of this process. There are some guidelines to allow them, but I've also said, Darren, I'm working with an attorney now. He said I can't look for work. So there's a lot of that kind of information there. I also pull in VR for folks because that's that, designated state rehab agency, and there's some support around there. So it is, again, like Don was saying, some of that education and kind of see where they're at, what's triggering that event, where they're saying no. So you can still provide those supports and activities because part of FCS allows us to do that engagement and some of those assessments to kind of work with them to kind of see what those fears are and then work with that as well. Yeah, Kelly.
Sorry, I figured I'd come off mute and just ask the question a little
Yay.
bit more clearly. And I have a ton of kids in the background, so sorry for my camera not being on and stuff. So I guess my concern is legality wise. At like what point? So I specifically have a client that has like a seizure disorder. And
Mhm.
so he's been told time and time again he cannot work, but he is on my caseload for employment services. So
Mhm.
I'm like, at what point is he like, he's like, I can't work. I physically am not there. Like, at what point is there like, okay, you're no longer eligible for employment services because you've been told by medical providers you can't work?
And I've had some situations where the medical providers have said, I don't think this is a good idea. I asked somebody who also had a seizure disorder and extreme fall risks. So we said, well, let's try something in an environment, and we got the person into VR so that we could do a community-based um,
Assessment. Yep.
assessment plan to kind of see what the risks are, and is it just from that perspective of the medical providers? It's a good, valid one. I couldn't argue. And it turned out it was a very high risk environment, and because of the environment it was in, and the falls and the risk, we had some stuff, and so that we had to come back and look at some different options because he was tired of being at the rehab center. He wanted to
Yeah.
work in the community and do things. So we had to look at some different things, and I think we looked at some education options and some other things for him. But there's sometimes, a few cases I have been in, the doctors were like, "We are not supportive of work," but we still worked in the background to kind of see if that was valid or not, what that risk management is. And there's sometimes too, I've moved ahead when I've gotten the okay from the medical providers to kind of
Mhm.
support. I didn't want to alienate them. I didn't want them to
Right.
be the last to know. It's part of
Yeah.
that integration collaboration that Don talked about earlier.
And what is VR? You mentioned VR. What is that?
It's a Department of Vocational Rehabilitation. It's
Oh,
the
good to know.
state designated agency to really help people with disabilities. They started back at, right after World War I with people coming back from shell shock and physical disabilities and behavioral health issues in World War I. And they definitely refined all the support that they provide. So you do have to go through an application process. There's a lot of demand on services, so they have uh, a bit of a wait list process that they prioritize called order of selection. So it's really good to have help somebody through that process because they do ask for a lot of information, and there's that, hurry up and wait type thing too. After you turn the paperwork in, there's some waiting time to provide support, but we can use that FCS support during that process to help with that advocacy, build that collaboration, and see if they're eligible or not, or whether they'd be placed on the wait list due to their priority. Is that
Well,
helpful?
keep in mind, most medical providers have no training in disability. They don't truly understand the options, and when you refer somebody to DVR for an assessment, the providers that they have do the assessments are trained in disability. They do understand kind of the ins and outs of that. I would almost, I've said so many times over a period of time, in the 35 years I've done supported employment, there were a handful of folks that truly could not work. Very often it was related to a physical issue, um, but it was maybe 5 folks in 35 years. Most people can work with the right job, the right accommodations, the right support. I will say one of the things, if you start getting questions like I can't, and you think maybe the person could with accommodations, and you want some kind of basis to be able to discuss it with them. The Job Accommodation Network, or JAN, which is available online. I hope it still is. I hope it's not one of the programs that's ended up being cut. I guess I
Not
haven't.
yet.
Geez, I just thought of that. I don't know. But the
Yeah.
Job Accommodation Network, I wish I hadn't thought of that. You can go into the website and look up based on kind of a diagnosis, if you will, what kind of accommodations might be available for a person based on their disability. They also have, if you have a specific scenario with a person where, and I don't know about you, I'm not an accommodation specialist, never have been. I seek the professionals for that. But if um, if you get really stumped and you're working with an actual person in an actual job, you need more than what you've been able to look up. They at least have had real live individuals that will consult with you for free. So be aware that we don't have to be accommodation experts, thank God. That's only one of the resources out there that can help to figure out what accommodations might help a person to be successful. I don't ever want to portray that we are, and I see Kim says Jan is super helpful, and Scott put in it's still up. Good news. Thanks, Scott. Put up the link for that. I don't want to ever come across as we don't respect medical professionals, but do be aware, so I started in a master's in social work program about a year before I got into this job. And when I got into this job, I no longer had a caseload, so I didn't finish up my master's and I didn't do the practicum. I no longer had a caseload with which to do one, and couldn't work out the time requirements. In that first year of social work school, there was no mention ever of even in the diversity class that I attended, there was no mention of supported employment for individuals, and students and instructors asked me about what I did for a living, and I told them, and just no knowledge. They don't teach that kind of thing in kind of general college classes, and I don't think they teach it in general medical classes as well. I see Darren put in the DVR website, and Maria says, may I ask the dates reflected in the original invite? Are still orientation, or are they progressing from today's orientation so we could use this to register for them? Could you elaborate a little bit more, Maria, please? Kim says, I want to get my master's and focus on disability studies, but it's difficult to find a program that does that. Yep. Also not sure I can handle work full-time and afford school. Amen. I've still got college loans, this many years later from 2018 till now. So for half a master. So yeah. Oh, Maria says if the next days will be a continuation of today's. And Kim says, I'm terrified of loans. Amen. So Maria, we do this webinar once a month. Because we answer a lot of questions and things, everyone is slightly different. And this one's being recorded, so you could go back and watch it again if you wanted to. But the next one will have the same PowerPoint, and I can guarantee it'll be a little different because we'll be responding to, like we're doing today, the questions and that kind of thing. I hope that answers your question.
Great questions. Thank you, everybody.
Yeah. I think we're on to the next slide. So I'm a little OCD. And they always say the 8 principles of IPS. Well, there's actually 25. And if you look at the 8 that we just went through, here's the stuff that's missing, which is when this is my slide. I was like, I don't like the fact that they left this stuff out. Darren's laughing at me. He knows me. Poor guy. So one of the things that IPS encourages is a caseload of 20 or fewer. Now that's for supported employment in IPS. I know with housing, it's less than that. It's 15, I believe. And correct me if I'm wrong, Anessa. The idea being
you got it.
Thank you. Hey, I'm learning. The idea being there, very honestly, it's a self-care kind of thing in part. It's a care for the individuals on our caseload thing in part. The idea is to have a caseload that's of such size that you can afford to do the support with the people on your caseload. Sometimes job coaching is a need. At least a little bit of support when a person gets a new job is of need. Sometimes a fair amount of support. But this caseload of 20 or fewer is really about the idea that you can do your job, the person can get what they need, Nobody's stressed out, and it all works. Now, having said that, the agency that I worked for decided that monetarily a caseload of 25 would bring in enough income to support the program. So when we had fidelity reviews, this caseload of 20 or fewer is a 1 through 5 scale. It's got a 1 through 5 rating. We always got a 4 because we had a caseload of 25 as opposed to 20, and that was okay. We were still able to do what we needed to do, still able to provide the supports and things, weren't overburdened, if you will. And the people got good services. So there's some leeway here. This is for the highest fidelity. These are the things. Brian, I think you were asking about collaborating with DVR. So what the principle is about is if a person is receiving DVR services and services from an FCS program, you should be collaborating, talking, meeting regularly, and having that contact. In real life, Division of Voc Rehab is in an order of selection, which is a fancy way of saying a waiting list. And what that means is when a person applies for services, DVR staff determines eligibility. They have 90 days in which to do that because they have to get medical reports and things to back up their decision. So they've got 90 days to get the doctor's reports and things to say, yes, the person truly does have a disability. Then they have another 30 days in order to write their service plan. And so it's kind of a lengthy process to get into DVR anyway. With the order of selection, unless a person falls under the category that they name most significantly disabled, they may not get services right away after that, kind of, what is it? 90 and 30 is that 120 days. Yeah, math's not my strong suit. So they might be put on this waiting list. In the past, I've had people wait months or even years before they came off that list, if ever. So a lot of agencies have not been referring to DVR. Now, one of the other issues related to that is DVR counselors, voc rehab counselors, aren't actually the ones that do the job search for the folks on their caseload. They hire community rehabilitation programs, CRPs, community rehabilitation programs. Some of the FCS providers are also CRPs. The agency that I worked for was an FCS provider as well as a CRP. And so what happened is when we were working with a person and they were in supported employment, if they got opened up with DVR, we switched them over to kind of CRP coding so that we weren't double dipping. The challenge is avoiding double dipping because Medicaid gets crabby. DVR gets crabby if you're billing two systems for the same service. Everybody gets crabby. You can't do that. CRP is Community Rehabilitation Program. They're contracted with Division of Voc Rehab in order to provide those services like helping a person find a job or doing a community-based assessment or a variety of the other services that DVR offers. So if you are an FCS provider and somebody from a CRP calls you and says, hey, we're working with Don now, you don't get to work with him anymore. It's because they're afraid there will be double dipping going on. It doesn't have to go that way, but a lot of providers and actually some DVR counselors are pretty insistent it's got to go that way. In a perfect world, you could both still work with the person, you just can't provide the same service. So if as an FCS provider, you've been doing job search with the person and a CRP comes on board, you can't do job search anymore. But you can help them get their driver's license if they've lost that, or a food handler's card, or clothing for interviewing, or figure out how to do transportation, or all of the case managing kinds of things that we do in supported employment while the CRP is doing job development. But it takes close cooperation. Brian, is this answering the questions that you had in regards to kind of the braiding thing? You're really going to braid if you are an FCS provider and a CRP. I mean, you're going to have two sources of income. You're going to do separate services so that you don't double dip, but that's kind of where the braiding comes in. So Darren and I have been working really hard with DVR to try and teach VRCs about how both agencies can work together. The CRPs and the community rehab programs and the FCS providers, we're not quite there yet. So if one of you gets a call and they say, you have to close the person because we are a CRP and we're going to work with them. I see Brian says it is possible for DVR to provide employment and FCS to provide education. Yes, it could be. The thing that's going to go on there is just strictly from the benefit of the individual. Can they tolerate doing school and working at the same time? I've already seen in the comments, and I know I experienced, I couldn't do both. And so it really is a matter of, can the person do that? Can the job seeker tolerate that? So, but yes, it could be done. Sabrina says, how can we access some additional and more in-depth training? Is there a calendar somewhere or mailing list? So we do a variety of monthly trainings. Rutgers does some of them for us. We as the FCS trainers do some. That YouTube channel that I put in the link has recordings of a bunch of the old trainings. If you want to know what new trainings are coming up, you let us know and we'll put your name on the distribution list, so that you get a newsletter, and in it will say here's the trainings and here's the links to register. So hopefully that answers the questions and we're up to speed with that. Anessa says I will get you added. Bless you, Anessa. You're a delightful human being. Employment specialists provide only employment services. So 1115 is not the first Medicaid waiver that the state of Washington had. Years ago, there was one called the 1915 B3 waiver. It allowed us to bill for supported employment, like the 1115 is doing. It ended up not being statewide, and so the legislature did away with it. They opted for us to no longer have it. At that point in time, the agency that I was working for said, okay, Don, you're going to be a case manager. Your specialty will be supported employment. I want you to guess how much time I spent doing supported employment, because I had folks that came in saying my meds have been stolen. I can't get to the pharmacy. I can't get to the food bank. I'm getting ready to get evicted. And the list went on and on and on, all the emergent stuff that goes on with so many of the people with whom we work. I did almost no supported employment. IPS figured this out. IPS knows that in order for employment not to take a back seat, it is best for the employment specialist to provide only employment services and not a bunch of the other stuff. I've lived through it. I'm here to tell you, they made a good choice. It is hard. It also is a scenario where I was allowed to be an expert in employment. I didn't have to be an expert in employment and housing and I got to focus on one area and become really knowledgeable about that area and become a subject matter expert in that area, as opposed to, having to be kind of spread out that far. I will say, after the 1915 B3 waiver, by golly, 1115, it's statewide. We didn't make that mistake again. Yikes, with 500 and some odd sites. DVR stands for Division of Vocational Rehabilitation. Fourth one, employment specialist is vocational generalist. What that means, just a bottom line simplify, is when a person is referred for supported employment services to you, you do all the steps. You do the vocational profile or the supported employment assessment. You do the job development. You do the job coaching. You do the long-term follow-along. You provide all of the services under the employment specialist umbrella. So that generalist just really means the person doesn't have to tell their story over and over again. Because I don't know if you've ever heard it, but I can understand it's re-traumatizing sometimes for a person to have to tell their story again. And, this kind of system avoids that. Darren, did you want to take on the next three? I know we typically divvy them up.
Sure. So we talked a little bit about under the systematic part, but there's the focus of employment specialists spending time in the community. Definitely, when I was running a program, 65 is a very high number. That's for highest fidelity that you're spending, the majority of your time in the community. But I really encourage programs to kind of start with a figure, whether it's 25%, 30%, 40%, whatever that's look like, so you can build that momentum and support folks being in the community. Sometimes agencies really don't like people being out in the community, so there could be a bit of a culture change too. That's one thing. It's nice to have this evidence-based practice to kind of leverage that support, and so this is why it's important that we do that. But definitely, that's the high end. But in my experience, the best outcomes are going to be when your staff are in the community, building those relationships with the individual and with employers to really have that kind of win-win relationship and get people into positions and then provide the retention or those follow-up supports to make sure they're stable in their positions. Um, Disclosure is, again, it's kind of like one of those conversations that you need to have when somebody comes into the program. It's part of the career profile from IPS, but it's meant to have that ongoing dialogue. A lot of people I've initially met is like, Darren, I don't want you in my business, and I don't want you sharing information in the community about my diagnosis, my medication, maybe behaviors, whatever that might be. So it's going to take some time to build a relationship where they feel safe and confident about how you're going to approach employers and what information you're going to share. And sometimes I would go out with the people to kind of do that role modeling and demonstrate. This is how I interact with folks. This is the information I'm asking for. Basically, I'm trying to get to know the employer, kind of what their needs are. What kind of people do they like to hire? What are some of those things that would make somebody a good candidate for this employer? Those type of things. Sometimes even at the end of the day, people say, no, thank you, Darren. That's fine, but I've addressed it multiple times and I've tried different strategies to do it. Because if you just have one strategy and people say no all the time, I think it's always good to look back at the program. How am I engaging with people? How, if I'm getting any buy-in, about the process? And I think people meeting you for the first time, you're a bit of an unknown element. So the trust ratio might be a little bit lower, but if you have appointments and developing some ideas and working closer together, that perception can change because there might be a little stigma about that too, is how people go out in the community and share information. When I was in behavioral health, I had a business card, it was a really long name. So I was already disclosing I'm working with the behavioral health population. Some people didn't like that. They didn't like that association. So kind of be sensitive to some of those things. Sometimes I'd go out and talk to employers and they would say, oh my gosh, I have a nephew or I have a cousin or, I have a family member who is struggling with that as well. So sometimes it's really nice to kind of see that level of education in employers. And I think that's only changed for the better over the last 10 years. We're also talking about sort of engagement that we want to be out of the office to do some follow-ups. Definitely, we're going to use phone calls. We're going to use emails. We might check in to see if they have a wellness plan and maybe there's a significant other or emergency contact that we can use to find out. But if something happened where people stop coming, we just don't want to say, okay, Darren's case is closed. Let's move to the next person. What kind of things are you doing to actively engage and do some of that follow-up? So that we can say, hey, we're concerned about your safety. We haven't seen you for a while. Are you okay? Is there anything we can do to help in this interim? People do go through cycles of like, well, okay, employment's really primary today. Next week, it might be a little bit lower or might go up. Sometimes it vacillates or kind of like a curve, a wave curve. But sometimes there's other things and the life's going on. People might be facing court dates. People face medical procedures. People face medication changes. There's different things that impact folks within their family, their individual or external things that they can't control. And it's always good to kind of find out a little bit more before we get to that piece. And that's why like IPS has this strategy to make sure we're engaging. Sometimes I would go with my staff out in the community and go knock on doors. There's one time I went out to find out somebody he had been working, things were going really well, and then contact dropped off for like a month. I wasn't sure. So I went to do a home visit and the landlord said, nope, so and so left for Texas. They're no longer here. So sometimes things happen. You're the last to know, but through this sort of engagement, hopefully we're not the last to know that we have that robust relationship with folks to be able to support them with that. I noticed there's some things coming up in the chat. Yeah, some of those when you're having that support with people and doing some of the networking, we want kind of, reach out for some of the collaborations. Maybe there's other people in the job seekers life that would be important to know, or maybe just learn about who they identify as important people in life. I've had some people, say the librarian, the person at the food bank, the bus driver. That's my support network. Those are my natural supports. It's kind of interesting on some of the things that information comes up when you start to learning about people and they feel comfortable and want to share with you some of the challenges that they might have. I agree. If there's some job fairs out there, some community things, it's such a great way, one, as an employment specialist to get integrated and learn about the community, but to kind of be that role model and demonstrate how to engage with people. I think that for me, it can be a very stimulating environment. I don't want to minimize that, but it's a great learning experience because then you can just debrief. Well, how was it when you walked over to Kaiser? How was it when you talked to somebody in the city of Seattle? How was it when you talk to Pizza Hut, whoever those are, those type of things. So you can do some real-time adjustments and just observe. So I do like those. Hopefully there's still some great events going on out there that people are able to take advantage of.
I will say, so for our team and for you guys, there's a boatload of slides left, but they are things like WellPoint. And I don't think we have WellPoint staff here today to talk about WellPoint. There's the TAP program. There are other slides like that. I think Glide Path is in there. And we've had problems with Zoom. And so this particular training was scheduled a little later than some because Zoom finally decided to participate and cooperate. So we don't have some of those other folks here to provide those sections. Since we're probably going to miss out on doing them today because we've got a bunch of slides left and we're not there yet, feel free to sign up for another one of the FCS 101s, and hopefully the next one will also have everybody here to present their section. And Darren and Nessa and I will learn how to be quicker.
Maybe
Miracles
no
happen.
guarantees.
Miracles happen. It could happen. Sorry, Darren.
No, that's right. So you can see on the slide some of the information. It's really great, similar to housing, that there's the pre and post services. So there's a lot of flexibility on how to tie in your supports. Again, just in that medical necessity framework, why is it important that we're supporting these people in their journey to employment? Is it their anxiety? Is it the stigma? Whatever those type of things are that you could weave into a lot of the information. Definitely with both sides of the house, we do those collaboration services, those collateral services, and transportation could be like that. Medicaid does not pay us to take people to job interviews at the pharmacy, but maybe you could talk about some interview strategies or how to decrease their anxiety with some grounding or breathing exercises to help them with some of the procedures. And I also want to highlight supported education as part of the FCS, array of services. So it's definitely, some of those same things come up to be able to go out and visit somebody on a campus or show them where the FAFSA office is or show them where the disability services are, show them where, maybe there's a cafeteria or something like that as well. And again, definitely, just focusing on how you do the collaboration. Definitely it's a pillar of the services here. And over to you, Don.
All right. So as we look at these, when people ask me all the time, what kinds of things can we bill for? I want to make sure we're really clear. These are the WellPoint contracted services, which means these are the things you can bill for. So if you don't walk away with anything else, and I hope you walk away with a lot else, that's one of the things that you take from this is that the slide that Darren just talked about in this one, these are the services you can bill for. You can see with this one, there are a lot of overlap with the pre-employment services and the employment sustaining services. Career advancement is one that I think is seriously cool. 100 years ago when I was doing supported employment, we would put a person in a job and kind of expect that they were going to stick there. Are you guys in the first job that you ever got? I'm not. I haven't had a boatload of them, but especially since I was in one of them for 21 years, but I've had quite a few, which means I've advanced. And that should be the option available to the people that we serve too, is career advancement. Supported education is very definitely part of supported employment. And could include things like I had a gal that I supervised that was great at taking people out to the college campus, walking around to allay their, kind of fears, helping to introduce them to the instructors, like I did with the gal that became the welder, helping them to apply for FAFSA. Those kinds of things are relevant too. You can see the job accommodation and assistive technology and negotiating with employers. And you don't have to do that on your own. There's resources out there to help you with figuring out what that looks like. Job analysis really is about what it sounds like, analyzing the job, the pieces of the job, so you can help to teach the person the different pieces. Or you can help them come up with a checklist, or you can help them with, whatever it might be in order to be successful in that job by analyzing the job. Job coaching is different. It's kind of looking at where the person needs support and providing it, and where the employer says the person needs support. And also part of that job coaching thing is helping the employer too. I will say that there's been a couple of times employers, when I've done job coaching, have asked if they could use the tools that I came up with. One of them was Safeway and Grand Coulee. Gal was a courtesy clerk, and I came up with kind of a checklist in regards to what needed to happen and when. And he said, can I have this to use with other staff as they come on? Absolutely. So that job coaching is helping the person, but sometimes it's also helping the employer. Benefits education, Darren covered very well. Asset development, as much as meaning, kind of the monetary piece of it, it's also the skill acquisition piece of it. I've gained the skills to move on to something else that, is a higher level that I want to do. And then ongoing follow along supports. Somebody said, and I can't remember if it was one of the attendees, one of the trainers, or exactly what, that sometimes when people get their house or their job or whatever it might be, they say, okay, Groovy, I'm done with you. We all know there's a honeymoon period in either case. We all know that when you're in a new job, you're being taught how to do the job and you're not really expected to do it yet. That's the easy peasy part to at least some degree. And so I would always say to folks on my caseload, I hear you. I know you don't want one more appointment to go to. You've just gotten to be busier. But can I check in with you at least in, like a week, a month, or whatever? And more of the time than not, people would agree. I'd kind of say, could you just humor me? I'm not going to pester you. I just want to be able to check in. And an amazing amount of the time I get to that check-in and they're like, yeah, I actually do need some help. So if you can talk people out of the idea of just bang, closing and not having access to that support, it's potentially a good thing to do. Questions, comments about all these things? And I see Philip says, would GED instruction / tutoring prepare for GE test be a billable service? I always encourage you, if there's a service out there that exists, a resource out there that exists, have your service be connecting the person with the resource. Having said that, if there is no resource, you can be the resource. I know that the community college in Moses Lake, the GED instructor is a buddy of mine now. And there were times when I didn't provide that testing training, but I had a person a couple of times in my caseload that was so nervous they couldn't go to the GED classes themselves, just alone. And so I went with them. That's part of the way the GED instructor became my buddy. But I would actually go with the person and kind of help them where they were, maybe having some challenge with staying there because they were nervous, or having some challenge asking the questions that they needed to ask, or whatever it might be. And I would coach them on those pieces with the idea of creating independence, so that if they came into a scenario in the future where they needed to ask for help with something, I'd kind of help to promote their courage and promoted maybe some ways that they could do that. So, yeah, Darren says great questions, and there's a lot of great questions. I always try and err on the side of, does a resource already exist? Help them connect with the resource. I see here's our WellPoint section, and it's pretty lengthy. You've got the slides now from the chat. If you didn't find them, let us know. We're no longer going to send them out after webinars. We're starting to enter them in the chat so that folks can get them immediately. And because very honestly, we've gotten to the point of being so busy, sometimes they didn't get sent out. We don't want to do that to you. So this way, and I see Darren entered them again. Thank you, Darren. This way, you're assured to get the slides from this training because they're in the chat for you.
Yeah, and reach out because I know there's some people that were looking forward to the next session. I don't think we're going to do it justice in the few minutes
Nope,
we have left.
nope, we're not.
But we're always available, for a consult or questions or set up another time to
We
chat.
are indeed. Well, I don't know, Darren, if you got a chance to see, but Anessa said we need to make this a 3-hour training, and I wrote back and said, "Yep," and she's already on it. So we're going to see if we can make the next session longer. I hope that the information that we shared with you is helpful and viable. If we can cut something down, let us know because that would help. Kim, thank you for letting us know that you would attend a 3-hour training because I do think it may be the way that we need to go so we can make sure to get in the tap and the glide path and the yeah, AHA and all the other things. Bert, I see it says you found the slides. That's good. Okay. So I think we're up to speed. All right. Are there questions that we missed?
Folks have been great about putting things in the chat. If there's
You
anybody who wants
have
to come
been.
off mute or raise their hand and
Yeah.
come off to ask any questions,
Yeah.
we're
Thank you for all
available
the
for
good
that.
questions. I'm going to tell you just briefly. I know some of the folks in this group I may have worked with. I'm getting ready to retire the end of October. Um, I'm not sure if Anessa and Darren are going to be providing this training with after October with the two of them or who might be part of it. It will continue. You may not have some of the same folks in it. I would encourage you if you have questions specifically for me and you need some individualized training. I see Anessa says we will continue the training. Go, Anessa. Thank you for the kind words, Brian and Demi. If you have individualized training that questions about stuff that I said specifically, feel free to reach out to me between now and the end of October, and I'm happy to schedule some things if needed. So, thank you, Maria. Yeah, it's bittersweet. I am still, you can tell how passionate I am about supported employment. And it's just real obvious. That doesn't go away with retirement. So I will figure out ways to be involved still. So anyway, any other questions? I mean, heaven forbid we could get done 3 minutes early without having gone through the whole slide deck. Oops. All right.
Well,
Thank you so much for your attendance.
I just want to let people know we do have, our contact information here. If you have any questions, please feel free to reach out on the slide deck. Reach out. We'll do our best to answer any questions you have or set up something one-on-one if that's helpful as well.